Welcome to our latest episode of the Lebanese Physicians podcast. And today our title is going to be Breathing Better, Using Digital Innovation to Transform Asthma and COPD Care in Low Resource Settings. And our guest today is Professor of Oncology and Pharmacy at Kingston University, Dr. Shereen Nabhani, who is involved in a big project actually looking at multimorbid chronic respiratory illnesses, and it's called the MULTIPULM project in low resource countries and comparing them to high resource countries. Dr. Gebara, welcome to the podcast.
Thank you very much. Thank you so much for reaching out. It's a pleasure, really.
Yeah, it looks like we were discussing offline. Looks like we may have known each other from our days at AUH, or the American University Hospital in Beirut, back in 2000, 2001, I guess, a long time ago. But so can you tell us a bit about your journey? Because you were in pharmacy, but can you tell us a bit about your journey from pharmacy into academia and global health research at Kingston University?
Yeah, so I went to pharmacy school in Lebanon at the Lebanese American University, and I did my doctorate in pharmacy there. And then because I was trained, on the American way, my natural step was I wanted to do a residency. So I spent the next 2 years in the US, and I did a general residency and a cancer specialized residency as well. So my specialty, one and foremost, is definitely cancer. That's where my heart is. And then after that, like all Lebanese people, we try to go back and see how we can give back to Lebanon and how we can work there and thrive. That's what I did. So I moved back and I had like a split position, which was academia, but also in a clinical setting. So I got my fix of teaching, research, but also staying close to patient care. And that's where I would supervise future pharmacists in hospitals such as AUH. And that was it was a lovely experience because I got to go back and work where I trained, see it from the other side, bring back the experience that I got from the States. So it was a really good experience. And I got involved in very exciting projects such as, and I don't know if you remember, do you remember the VOC, the Volunteer Outreach Clinic?
Yes, I do. Yep. And I've been there multiple times actually.
Oh, so maybe that's how we overlapped
Maybe
as
that's
well.
what it is. Right.
Yeah. So, and the VOC was very close to my heart. So one of my students got me involved. He said, "Oh, there's this really exciting project. There's medical students and attending from AUB who supervises." And I joined, and we grew the service. There was a pharmacy service after that, and so yeah, it was a lovely time for me in Lebanon. But then I also met my husband, who is half Lebanese, half British, and in 2008 he wanted to move back to London, and that's how I moved to the UK and had to kind of start all over, because in the UK I wasn't licensed as a pharmacist, and there was no oh God, you're gonna have to edit that out. It's not reciprocal between. So obviously I'm licensed in Lebanon, but I'm also licensed in the US. But in the UK, had I wanted to get my UK license, I had to go back to school and train again, and that wasn't really in the cards. So it was a difficult time to transition into the UK system of doing things, different ways, different culture. So, I mean, we can talk about that later. But so it was a difficult transition, but then slowly but surely I found my network, I found my peeps, grew within there, grew my research, got funding, and got introduced to the whole EU-funded projects, because that's what MULTIPULM is. It's an EU-funded project. So my first EU project was over 10 years ago, so maybe 13 years ago. And I was introduced to the whole concept of these huge consortia of experts, healthcare professionals, patient societies coming together to work towards a shared goal over 3 or 4 years. And usually these are highly funded but very ambitious projects where they want you to deliver the world. And they're bringing together people that haven't worked together before. And I know you want to talk about that later, because that's a whole challenge by itself. But it is a very rewarding experience, because the exposure to, colleagues from other countries across the EU, across disciplines as well, so it's multidisciplinary. Delivering on something that's so ambitious where the learning curve is so high is a lot of fun. It's a lot of work, but it's a lot of fun. So that's why since my first project in 2013, I've been involved in multiple ones because I know how good they are. So the latest one is MULTIPULM, and it's specifically around chronic respiratory diseases in lower and middle income countries.
Right. And so I guess I was going to ask you this question: what motivated you to focus on chronic diseases and healthcare systems in low and middle income countries? So partially, it's probably some of the EU-funded projects that you have been able to be involved in, I guess.
Yes. So, with these consortia, once you join one and you prove yourself, people then invite you back to join other ones. And at the time, my first project was around COPD, actually. So it was also chronic respiratory disease. And it was around how can we use technology and wearables to improve the monitoring of patients, but also the proactive care. And it was such a successful project, and the people that I worked with. So I was responsible for doing the needs assessment and also the evaluation of the clinical trials. So that's kind of my expertise in these EU projects. And so from then on, because I kind of proved myself and people liked working with me, they then kept inviting me back. And that's how I stayed within chronic respiratory diseases, even though that's not really my first expertise. My first expertise is cancer and will always be.
Right, because that's an interesting part because you're a professor of cancer and pharmacy
Yeah.
at Kingston University, but you're also involved in these projects on chronic respiratory diseases. So what is the MULTIPULM project, and what problem is this project trying to solve?
So again, this is a very ambitious project. Every time we look at the proposal that was approved, we're like, we promised what? So it's a highly ambitious project, and it's maybe 10 European countries working towards delivering a digital ecosystem that can help deliver integrated care for people with chronic respiratory diseases, but also with comorbidities. So, I mean, as you know, we shouldn't be treating patients as organs. But unfortunately, that is the reality across multiple healthcare systems, is that they're divided by specialty. And a lot of times, the specialists that see people who have multiple comorbidities often don't speak to each other. So you get that fragmented approach, potentially duplication of therapy, polypharmacy, side effects that can come across, which may compromise outcomes. And that's specifically a problem in undersourced settings. So the countries where we're going to be implementing the pilots are Brazil, Serbia, and Turkey. And the idea is that by the end of the 4 years, so we only just started, we're only within the first 7 months of the project. The idea is by the end of 4 years, we would have trialed a digital ecosystem for patients living with chronic respiratory diseases and comorbidities to help them better monitor the disease, not just the lung disease, but also their other comorbidities, all in one ecosystem. And at the same time, have a proactive approach. So during the monitoring, if deterioration is picked up, or if, for example, the mental health is deteriorating, these could be picked up with the digital ecosystem that we're designing. So that's the idea. Yeah.
Yeah, so basically it's like a digital ecosystem that's going to be able to detect patients in these low middle income countries or detect comorbidities that are happening earlier, I guess.
Yeah.
And so my question for you is like, it's very interesting to me because like, I practice here now in the US, and we see a lot of patients with multiple comorbidities or multiple illnesses at the same time because of the obesity epidemic and stuff like that. But it seems like multimorbidity is also becoming increasingly common in low middle income countries. Why do you think this is happening earlier in these populations compared with high income countries?
So with chronic respiratory diseases, in terms of the high burden that they have in low to middle income countries, I mean, it's multifactorial. So you could say it's smoking, you could say it's pollution, but newer studies have shown that it could also be problems in early lung development. So when the child's lungs are developing, if there's exposure to malnutrition or exposure to pollutants at that point, that can also then predispose them later on. So it's that initial lung development as well. So it is multifactorial. There's also biomass smoke, so burning of garbage and household garbage. So again, that smoke had lots of chemicals as well that can predispose people to asthma and COPD and other respiratory. So it is multifactorial. Poverty potentially is at the heart of it, with creating these underserved communities where they're not getting their conditions, their living conditions aren't ideal, with malnutrition, pollutions, biomass smoke, all of that. And then on top of it, a system that cannot detect them early on. So you've got delayed diagnosis, and by the time they're diagnosed, they're advanced, and they've got other things happening as well. So it's quite a complex picture, really.
Right, it is interesting because now you see in high income countries, like, smoking is becoming sort of a taboo, and people don't smoke as much. But then you go to other countries, even like when you go to Lebanon, you see how much people are smoking there. And of course, like, air pollution plays a huge role in this. And even when you were saying this, I remember too that there's some studies even in like low income housing in the US, because of smoking inside the buildings and stuff like that. There's a higher rate of asthma in these populations. So that's an interesting part. So we talked about this. So basically, these patients, right, they are at higher risk of developing asthma, COPD, and some other respiratory disease, even maybe, I guess, like employment-related diseases, maybe such as asbestos or silica dust or stuff like that. But when these patients develop these diseases, what are the biggest challenges they face when trying to access coordinated care in these countries for their chronic lung disease?
So I did mention it before. It's predominantly delayed diagnosis. So what we did as part of the project, and that's part of my role, is understanding the picture. So we map out the care pathway first to see how do people get diagnosed, how do they enter the system, how do they get referred, how easy it is, where are the bottlenecks. And so what we are doing now is we've mapped it in Turkey, we've mapped it in Serbia and in Brazil. And one of the commonalities is the delayed diagnosis, because people's first touch point is going to be the family physician or the general practitioner. And oftentimes, these healthcare professionals do not have, for example, spirometry to diagnose. So they have to refer into specialized services. But that's a huge bottleneck, and it could be months and months before people's appointments come round. And by the time they get diagnosed, things are compounded and more severe. So we have a huge problem of delayed diagnosis. Whereas if I reflect maybe on care in the UK, so diagnosis does happen in general practice because of access to these diagnostic modalities such as spirometry. So we don't need to wait for referral to specialized services to get the diagnosis and to start treatment. So that is a huge burden, is the delayed diagnosis.
Because basically there is in-office spirometry, so you don't have to be in a full pulmonary function lab to do your spirometry on the patient. But so basically what you're saying is, one is we want to try to address delayed diagnosis so we can diagnose these patients earlier and treat them earlier. And so how is MULTIPULM going to be able to deliver that earlier diagnosis for these patients?
So MULTIPULM predominantly is about living with chronic respiratory diseases. Now, so I'll talk about that, but I'll tell you how we're trying to push back. Yes. So when we designed the proposal and the studies, we are recruiting participants who are already diagnosed, but what we want to do is provide them that coordinated care, so that on one ecosystem or on one platform, they can monitor their diabetes, their hypertension, their mental health, and their respiratory condition all at the same time. And all of that information is in one place and shared with their healthcare professionals. So that's the idea. But I mean, I just came back from Serbia. We had our plenary meeting. And one of the innovations, one of our partners has a digital solution that allows analysis of lung sounds. So even if so it's not meant to diagnose by itself, but if you have somebody in general practice, for example, who is not an expert, but who will have access to the system, it can help diagnosis. So we are considering how we can deploy this to support general practitioners in Turkey. So we're going to go off script only because we've got this opportunity. We've got this, this technology, and obviously the developers just want to validate and test it. So we're going to explore how we can use that in Turkey to support earlier diagnosis. But the project was designed for the management, the proactive management of people with chronic respiratory diseases and comorbidities.
Right, because once people are diagnosed with COPD and asthma, then the question is number one, management. Number two, maybe education about their illnesses and diseases. And maybe number three is recognizing when and if they develop like an exacerbation or an attack of their disease and how to treat it early. So MULTIPULM, I guess, aims to deliver, from what it says, digitally supported integrated care. So what does this look like in practice in these countries or for these?
So as I said, we've only just started. So that means we don't have anything ready, but I'll tell you what the vision is. So at the moment, we've got 6 or 7 different technologies that have already been tested in other populations, and these are our partners. So what they're going to do is they're going to integrate it into one platform so that patients recruited on the study, so when we come to implement this in practice, patients at home can then have access to these different technologies. So either the breathing games or the voice analytics or monitoring well-being and lifestyle and nutrition and micro coaching. So all of these will be integrated into one platform that people can use remotely, but the information is integrated into one database if you want, and then the analytics around it will help detect deterioration, will help detect who needs to be brought back for assessment. So maybe their mental health is deteriorating, or their diabetes is deteriorating. So the idea is that it's remote monitoring, allowing proactive intervention.
Exactly, with the patients, and potentially even maybe brought back for assessment, or maybe could it be phone calls to the patients to check them out and stuff like that?
Yeah.
To prevent. Okay. That's a great idea, especially when there's like limited resources, I guess, or limited availability of care. Like you don't want to be in an exacerbation and call your doctor and they tell you come in like 3 weeks to be seen, because then by that time you'll be in the hospital.
Yeah.
So one of the interesting things that I saw is one of the innovations mentioned is AI breathing games. So what are these and how do they help manage these diseases?
So the breathing game, again, it was tested for a different project, but we're going to adapt it for our. So the idea is that these are maybe games with stories, maybe that people engage with, but throughout the game, there are breathing exercises that they have to do. And the smartphone is used as a conduit. So you can use the microphone within the smartphone so that the patients can breathe in and out into it. And then these recordings of the sounds that the person is making as they're breathing, but also how long they can hold their breath, how long is their expiration, inspiration. This was based on a previous study where they were able to translate all of these recordings into metrics that translate into lung function. And so if the patient plays the game, let's say on a daily basis, then you can see whether their breathing is improving, getting worse, and then you can intervene earlier if needed. So that's the idea behind the breathing games, is to assess. So it's a surrogate marker for lung function, if you want.
Right. And this would be interesting because then you would assess would in this case early detection, earlier intervention lead to better outcomes in these patients. And so how do you think, because I know there's been in the US and maybe in the UK, I'm sure there's been a lot of telehealth platforms to monitor patients, prevent them, let's say, from getting admitted, or there's the concept of integrated COPD care and stuff like that. So how do these monitoring platforms and decision and support tools help clinicians deliver better care to their patients?
So yes, we do have these systems, which some of them are called virtual wards or hospitals online. They all have different terminologies, but it all boils down to the same thing, is that you're giving the patient some devices that they can use to monitor their well-being, be it their lung function, be it their blood glucose, let's say, or their blood pressure. And all of these readings then are triaged through a decision support system. And if anything falls out of the norm, then the healthcare professional is alerted. So for example, we did a previous study, it was also an EU project, whereby the patients had their rescue packs of antibiotics and steroids. And if their readings were compromised, then they would call them and say, it looks like you probably are going to need to start your rescue pack. And that way you have saved the patient the trip to see you. But also, a lot of times patients have a hard time making the call. So they start feeling unwell and they know what's coming. So they know it could translate to a trip to the emergency department or maybe a hospitalization. So maybe there's that phase where, should I call? Should I call? What if I'm wrong? I don't want to disturb anyone. I don't want to go to the emergency department for nothing. So they kind of delay it. And that delay sometimes could be detrimental and make the difference between a hospitalization or, the rescue pack. So in terms of healthcare professionals, how will they benefit? It will reduce the burden on them. So if patients are better controlled and at home, and you can intervene faster to control their disease and keep them at home, that is less burden on your services, but also less burden on hospital admission and disruption for the patient. So yeah, that's how I see it. I think I see everybody wins by having this proactive approach.
Right, exactly. And the other part about it, I think, is when patients feel that there's somebody involved in their care, they may be better to take like their medications. Like sometimes they miss their inhalers, probably they would miss them less frequently because they know there's monitoring of their situation at this point, that they'll be even more compliant and know more about their treatments.
Yeah, indeed. I remember speaking to one patient who participated in a study, and she said that it felt like she had a guardian angel on her shoulder just watching her, and she felt more secure that she was being monitored. And yeah, she really loved it.
Yeah, I'm probably learning more about her disease because I was discussing that I'm a pulmonologist, and like there's invariably a lot of some cases where the patients come and they're like, yesterday I saw somebody who's like, he had asthma, he hadn't been seen for a while, lost to follow up. And he's like, yeah, I'm taking my rescue inhaler a lot, and I'm taking like a long-acting inhaler that opens up my airways. I was like, are you taking your inhaled steroid? He's like, no, I don't think it helps me. And then I had to explain to him how important inhaled steroids are in asthma. And I think if you have somebody monitoring them, then they would be educated about their disease and not end up with multiple exacerbations due to that. So
yeah, I think part of the work as well that we're doing is we're building in some awareness and education. So part of the platform that will be deployed for the patients would be education around their disease, some not just infographics, but also maybe some animation around exactly how they should use the inhaler, because we know inhaler technique can be a huge barrier, but also, like you said, what's the difference between the reliever and the preventer and the steroid. So literacy, health literacy, can play a big role in how engaged the patient would be and how adherent they are with their treatment.
exactly, because also like inhalers are not like one technique. There's multiple inhalers with multiple different techniques that patients have to learn, so it's not that easy. So the thing is, you're working in multiple low middle income countries. We discussed probably now it's Brazil, Turkey, and Serbia, but these are three different countries with three completely different cultures. So how important is it to design these tools in collaboration, I guess, with patients and physicians in these countries? Because I assume maybe the tools in Brazil may be slightly different than the tools in Turkey.
No, definitely. No, that's why I said it's so ambitious. So what we're doing to facilitate that, so we definitely need to co-design everything with healthcare professionals and patients from each country. So we're designing, or we're creating these communities of practice. So one of our deliverables of the project is to create communities of practice in each country. And the members of these communities would be patients, healthcare professionals, maybe researchers, anybody who has a stake in the topic. And the idea is that we bring them together so that we can learn how to adapt each of these innovations to the culture. Language is the biggest one, but then as well, there's small cultural implications around, because I mentioned one of them, there's a game involved, but if the graphics within the game does not reflect the population, that can also reduce engagement. So there is a co-design phase. Even though these technologies are already, each one of them needs to be adapted for culture, for language, for use by engaging with patients. So communities of practice, we already started deploying these and creating them and creating activities so people would then learn about the project, but also learn to trust the project, because we need to recruit close to 2,000 people across the 3 sites. And so the communities of practice will help us recruit people, but also raise awareness. We can then do education, we can do training, and the co-design and validation of the user experience.
Right, and I think I bet there's going to be like refining of the tools as
Absolutely.
time passes by, based on feedback from the patients and the physicians that comes along. But one of the things also about this, but not only is it like addressing 3 different big countries, I get they're very big countries, but the other part of it is you're bringing together like 18 organizations from, as we discussed offline, I think from like 10 different EU countries.
Yeah.
How do you coordinate such a large international collaboration?
It's hard because our first meeting was back in September, and that's when I first met everybody in person. So we had an online meeting before, but maybe I knew 3 people from the whole consortium. So it's not just getting to know new people, it's also understanding how to work across disciplines. So within the consortium, we've got healthcare professionals, we've got researchers, we've got patient representatives, we've got policymakers, we've got engineers, AI developers. We all have different lingo. We're probably all talking about the same thing, but the way we express it is very different. So there's this transition period where we're trying to understand each other. We're all speaking English, but understanding the lingo across disciplines sometimes is challenging, but also very interesting. But so you've got this adaptation period in the beginning where you are getting to know everybody, understand how they express themselves, and then you need to hit the floor running, because the EU is very strict. They review us every 6 months because they're paying us a lot of money, and they want to make sure, and this is taxpayers' money, and so they take it very seriously, and they want to make sure that we are not wasting time. So it's hard, but at the same time very exciting.
Right. It's as if like the IMF is giving money to a low income country, and they monitor it every 6 months to make sure that the taxpayer money is going in the right direction. So that's important for sure for the taxpayers and for the project. But so any so far have there been any lessons learned, or I know the project's just beginning right now, but have there been any like pilot implementations or early results or lessons learned from the project?
So lessons learned. So what's interesting as well is that even the clinical partners they vary. So for example, we've got 2 clinical partners from Brazil. One is a tertiary center. So one is a rehabilitation center. So that means people who get referred to them have already been diagnosed, they're already on treatment. Their job is to kind of improve improve their disease state, improve the management. Whereas we've got other partners who are acute settings, so they're hospitals, so they're not tertiary, they're secondary. So we very quickly realized that the type of patients they're going to recruit is going to be very different. So for example, the tertiary, they may have been living with the disease for a little bit. The acute settings, they may have been newly diagnosed. So that also factors in how we're going to design the protocol of the study, because we have to design a protocol that applies for everyone, and then also get ethics. So the variety of the settings is definitely something that we need to factor in. Eligibility criteria for patients. So, for example, in Brazil, digital literacy is a problem, which means that they can't recruit every single patient that they see. So even though a patient might be eligible in every other way, but if their digital literacy is low, they are technically not eligible. So we're trying to think, okay, can we work around this? Because we don't want to exclude, we don't want to create an inequality there. But at the same time, they need to be able to use the technology and engage with it so that we can have a successful pilot. Another thing that came that was just in the plenary, there's one of the innovations which is interesting is a sleep tool. So it's an assessment, but also improves sleep. And so it's you have to put like almost like AirPods in your ears for it to work, because it produces these binaural tones. And we quickly realized that if somebody has a hearing impairment, they cannot use this. So that's a huge exclusion, because some of our patients are going to be older. Maybe the majority of them are going to be older. So that means this specific technology cannot be used for older adults unless we do a hearing test. And that's not possible because we didn't really account for conducting a hearing test. So we're discovering these things slowly but surely, which is helping us shape how we're going to design our clinical protocol.
Right, because the hearing, if something visual too, if somebody's blind and cannot see, then that's a problem.
Yeah.
So, and that was my next question for you when you discussed, like in Brazil, how the digital literacy is lower. And I think it also may impact, like I can think about Lebanon, for example. If you implement it in Beirut, you're going to probably be able to recruit a lot of patients, but there might be inequality, because then if you go to Akkar or some of the other provinces, you might not be able to recruit as many patients. So how will you account for that, I guess?
So I think there's a minimum requirement to how much we can compromise on that, because we need them to be able to engage with the technology. But as part of our community of practice, we are going to be raising awareness. So there will be a lot of sessions around bringing communities together to raise awareness about digital innovation, how it can help health management. So we're hoping that as an indirect outcome of these communities of practice will be to address digital literacy. So while they cannot be part of the actual trial, we can help improve their digital literacy so that in the future, if there's another opportunity, then they'll be ready to participate.
Right. Because I think my opinion is becoming easier these days, because everybody has like a smartphone.
Yeah.
And so you don't have to have a laptop or a computer at home to be able to access some of these apps. You can just do it on the smartphone, which makes it probably easier. So so you're going to create these apps and these digital tools, and right now it's being offered through the project, but afterwards, I guess, once they're proven, they may be offered outside of the project and they may cost money. So how do you make sure that they remain affordable for a lot of these countries and areas?
So part of what we've promised in the project as well is a health economic evaluation. So how much will it cost to deploy this innovation within a service or within a hospital, and how much cost saving will they have on repeated admissions or on unplanned appointments? And that would inform the policymakers within the area. So we can, if we manage to show that by deploying a relatively cheap intervention, because it doesn't really need anything fancy. Like you said, a lot of people have smartphones. And if we're using the microphone of the smartphone, we're not even needing an extra accessory. Then maybe the price of the app in relation to the cost saving that they're going to get and reduce burden on their resources, that's how we can convince the policymakers and the budget holders that it's cost effective.
Right. Basically, what we're trying to do is to say, you know what, if you use this app, you're going to reduce, let's say, hospital admissions by 20% or whatever, then just reducing these admissions would potentially pay for the app and more. So it's like sort of trying to cover.
So it has to be on a policy level. It has to be on a budget holder level.
Exactly. And so, do you see what role? So it's always like now everybody talks about AI, and these tools are probably a form of AI, right?
Yeah, yeah.
But do you see AI, I guess, playing a broader role in chronic disease management globally?
Yes, yes, and I think it should because the technology is there, and obviously the world of research is ahead of what's available in reality or in practice. But there's so many innovations, and I don't think we should be afraid of using AI. I know some people might say, "Oh, will it replace healthcare professionals?" It may replace healthcare professionals who don't use AI. So that's the thing. It's now a tool that if we use, we will become better healthcare professionals. And certainly, just by these digital tools that we're going to use in this project, they're very exciting, low cost interventions that can help us better manage the patients remotely. So why not? They're all using AI analytics to be able to, you know, to build the decision support system and to create the alerts and everything. So why not is what I say. But there's definitely a lag between what I know we can deliver and what is being implemented in practice at the moment.
Right, right. So now, since we're Lebanese physicians podcast, I guess we're both from Lebanon. So I'm going to ask you about the relevance of this project to the Middle East and specifically Lebanon. So also, like a lot of countries in the Middle East face similar challenges, if not, I think more challenges, especially when we see all these wars happening and all this stuff. Could models like multipolm work in Lebanon or the region?
I mean, now, our region is on fire, isn't it? And it's affecting the healthcare services, it's affecting the access that people have. And so if you deploy and if you increase the use of these remote monitoring platforms, you'll be able to stay connected to your patients and be able to know how they're doing, how their health is performing. So I think there's a huge role because I remember I can give you an example, and that example stays with me. We were talking about the volunteer outreach clinic. So we were seeing patients on a weekly basis, and then we had the war break out. It was the 2006 war, I think. Yeah, the 2006 war, and we had to shut the clinic for at least 2 months. And I remember I had one patient who had atrial fibrillation, and I was very closely monitoring his warfarin and his INR. And then over 2 months, the clinic was shut. We couldn't contact the patients. And then I see him 2 months later, and he had had a stroke because he couldn't have access to warfarin, his INR dipped. So what I'm trying to say is, had we mitigated for this, had we had a way to stay in touch with the patient, to support them remotely without being physically present in that clinic, it would have saved somebody this comorbidity that they have to live with. And so I think more so than ever in areas of high conflict, you need to have a plan B, and you need to be able to lean on technology to allow you to stay in touch with your patients and keep an eye on them. So yeah, so that's how I see it.
Yeah, I agree. And now, as we were talking about, thinking about it, like now there's a war obviously in the region, and I guess there's a lot of hospitals that are affected. But potentially, if patients have access to digital resources, they can still manage a lot of their disease processes through these digital resources rather than having to go in person to a hospital or to an area that's not safe to go to at this point.
Yeah.
So, as a pharmacist and researcher, what excites you the most about the future of respiratory care, I guess, and maybe healthcare in general?
Well, I'm very excited about multiple, definitely, because the different angles that we're working. So we're working with technology and cutting edge digital interventions, voice analytics. It's all very exciting for me because so that element is great. But also we are addressing health inequalities by trying to think about people who have low digital literacy, low health literacy, people living in rural areas and underserved areas. How can we support them? So I'm very excited. And then the idea of integrated care. So we're using this cutting edge technology to integrate care for the comorbidities. So the multiple project is very exciting for me, obviously. And I want to see how far we'll get and what kind of legacy we can leave behind. So for me, that's what's exciting me about for my immediate 5 years, because it's a 4-year project. So multiple is going to be in my life for the next 3.5 years.
Yeah, for a while, I guess.
Yeah.
And yeah, and I guess I'm not gonna, I mean, I think hopefully this initiative will be successful and then we'll see digital tools spreading in various countries to deal with chronic respiratory diseases. What advice, as we end this podcast, I mean, we can keep talking about, I mean, we've got a lot of things to talk about, but
Okay.
I'm going to finish it with this question. So, what advice would you give young healthcare professionals who want to work at the intersection of digital health research and global health at this point?
I would say collaboration. So, I mean, that's how I started, to be honest. So how did I get into the field of technology and AI? I'm a pharmacist, I'm a cancer pharmacist, but I was always very curious. And so my first collaboration was with somebody from the computer science department. And I came across him in a meeting. We were just discussing. And so we decided to collaborate and we designed an app to support people living with cancer. So that's how I got into the world of technology. We started really small. We didn't really have a grant. And from there, because of our work, then we were recognized by that consortium who then invited me to join them. And so I would always say, always collaborate, because you can do a lot more when you collaborate across disciplines. You can do far more exciting things when you collaborate. Start small and build on that. I would say volunteer yourself first. I always say, if you give and people see that, eventually you'll be invited to join a network, and then you'll be invited to join a research group. And then, so baby steps, but it's all around collaboration, being curious, starting small, but also giving first, giving some of your time first, and eventually it will pay back.
Yes, thank you, Dr. Gebara, for being on the podcast and for letting us know about this very important and innovative project, I guess, and that's going to be implemented in a lot of countries. So thank you so much.
Pleasure.